Okay, so I'm Dr. Gottschalk. I'm from the Family Care Center. I work in the Family Practice Department and the Orthopedic Department over at the Medical College of Wisconsin. My primary residency is in family practice. I do birth to grave there, and then I also work, my fellowship is in sports medicine. So I do a lot of education for the residency for musculoskeletal medicine because it is so important. It's going to be in your primary care office 24/7. So today we're going to be talking about the knee. And this is going to be the most common things that are going to be coming into your office. So it's very, very, very important. So our objectives, we're going to discuss the key elements of the history and physical. We're going to talk about how to form a solid differential when you're talking about a good history and physical. When do you image? When is it appropriate to do an x-ray? When is it appropriate to do an MRI? Do you need to even do these things? Our treatment options, after we've kind of narrowed down our differential, and then when is it appropriate to refer. So why do we want to talk about the knee? It's pretty much the most common thing that comes into your office for a complaint. It's very common. When I do a sports clinic, almost half, if not more, of my clinic is composed of the knee. So it is a very, very, very common complaint. If you're working with a population that does a lot of sports, it's a high percentage of injuries, especially ones that have quick bursts of acceleration, twisting, changes of direction, things like that. Those are large pivotal forces on the knee, and it often will cause injury. And then don't forget joint. This is a joint that is heavily affected by load. I always tell my patients it's a 1-to-4 ratio. 1 pound of body weight, you are over what is your goal weight. That's 4 pounds of pressure for your knee. And I often feel like that's a good motivator for them. If you could lose 5 pounds, that's 20 pounds of pressure for your knee. And when they hear that, 20 pounds, that really, makes them right up. I'm like, 20 pounds, that's a lot of pressure off those knees, and it can make a big difference. On the other side, we have a visitor. I don't know if I will be able to see the knee. I might. We'll see. We can bring it on in. So also you got to think about, age appropriate. Sometimes I see horrendous arthritis in people who are overweight just because it is a joint that is so affected by load. Okay. So if someone who has a BMI of 50 and they're in their 30s, sometimes their knees can make them look like they're in their 60s. It can be very affected by joints, so don't forget about that. It's a 1-to-4 ratio. So when I talk to the residents, I always tell them, don't get bogged down. A lot of times they're overwhelmed by musculoskeletal when a patient comes in because they feel like they can't streamline, they can't really focus. And I always tell them, especially for the major joints, think of the knee to be divided into 4 compartments: anterior, posterior, medial, and lateral. And where the patient's complaint is, think about what is the most common things that have been going on in that sector. So when we talk about anterior, we're going to be talking about Osgood-Schlatters disease or SLJ disease. So Osgood-Schlatters is apophysitis at the tibial tuberosity, so an irritation of that growth plate. SLJ is the same thing, it's just at the top part of the tendon where the patellar tendon attaches to the kneecap. So it's at either end of where the patellar tendon attaches. Patellar tendinitis, very common, especially people who do a lot of jumping, running, things like that. They come on in, a lot of pain in the anterior knee. Patellar femoral disease, biggest complaint of women that come into my practice from puberty to well into their 30s. You got to remember, as you go through puberty and your hips widen for childbearing, you come in at your knees at a sharper angle. This kind of messes up with the alignment of the kneecap. You get a lot of rubbing, and this causes a lot of pain. Very, very common. Bursitis. There's a lot of bursas in the knee. You got your pes anserine bursa, which is on the medial side of the tibial plateau. This is where your gracilis, your sartorius, and a piece of your hamstring all come down. You got to remember, a bursa is a sac of water that protects a ligament or tendon from rubbing directly on a bone part that is moving a lot. So we have a lot of bursas around our hip, a lot of bursas around our knee. You have the prepatellar bursa, you have your suprapatellar bursa. So a lot of little sacs of water there that are protecting that. If you hit it, if you rub on it, if you bang it, it can swell up and cause a lot of pain. Patellar subluxation and dislocation can often happen. People feel, they hit their knee. It can be either acute or traumatic, where someone like falls on their kneecap just right and pops it out of joint, or it can be something where someone just bends wrong and it just happens to pop out. Can be very common. And then osteoarthritis. The person who discovers the cure for osteoarthritis is going to be a very rich person, because it is something that is heavily affected by weight, by genes, and by how much damage we've done. Maybe we've been in an accident, or we tore our ACL as a teenager or something like that, something that's caused trauma to the knee. Those are the three most things that can really accelerate your arthritis. Can't do much about genetics. We don't pick our parents. We can do a lot about our weight, but in the United States, we have a huge problem with weight, so that becomes that really affects our knee and osteoarthritis. And then we can try to minimize the amount of damage that our athletes are doing to their knees, but sometimes we can't. Once it's been done, it's been done. Then posteriorly, we think about hamstring tendonitis and sprains. Very common, especially sports that are doing quick bursts of acceleration and deacceleration. Baker's cyst. A lot of pain in the back of the knee from a Baker's cyst. Just think of the Baker's cyst as a bubble blown out the back of the capsule. So you got to think about your knee capsule. When the knee gets irritated, it produces too much fluid. Your knee has synovial fluid in it to lubricate the joint, so that when you bend the knee back and forth, you get a nice glide. If you irritate the knee, arthritis, bang it, bone bruise, tear your meniscus, tear your ACL, that causes a huge stretch on the capsule. That capsule, after a while, begins to fail a little bit, and it blows a bubble. Kind of think of it as building an auxiliary room to hold all that extra fluid. The biggest, softest place to blow a bubble out that has no resistance is the back of the knee. So people will often get a bubble out the back of the knee called a Baker's cyst, and they'll often come in saying, lots of pain in the back of the knee. But you know what, Doc? Sometimes it gets bigger and smaller, and that is depending on how irritated the knee is. You can actually have the Baker's cyst fill up when it's very irritated, and then as the knee gets less irritated and stops producing so much fluid, you're walking around, you can actually pump that and deflate the Baker's cyst. So it's not uncommon that people will be like, sometimes I see a huge bulge in the back of the knee, sometimes I don't. And then posteriorly, osteoarthritis. Osteoarthritis can be found pain in all sectors of the knee. So medially, big players medially, meniscal tear, MCL sprain. Those are very, very common. You got to think about the meniscus is intra-articular. So if you hurt your meniscus, the whole knee should swell, because you're in that whole joint capsule. You sprain your MCL, you have two pieces of the MCL, a deep piece and a superficial piece. Both of them are either extracapsular or melding with the capsule. None of them are intracapsular. So when you sprained your MCL, most of the time you get swelling just on the medial side. I always tell the residents, nothing makes me more irritated when they come out and they say, well, he had an injury, something happened, and the knee swelled. And I say, where did it swell? And they said, it just swelled. No, you need to ask, did the whole knee swell? Did it swell in the front? Did it swell on the side? If you're just getting compartmentalized swelling, then you're talking about structures that are outside the capsule of the knee. So not the ACL, not the meniscus, not the arthritis, not a bone bruise. So you got to think about that kind of stuff. And then laterally, we're going to think about another meniscal tear, LCL strain, which is very rare, and iliotibial band, friction syndrome. The iliotibial band, which comes down the side of the leg, is a huge problem for hip pain and knee pain on the lateral side. Causes a lot of friction, there's a bursa there, causes a lot of irritation of the bursa. So you always want to see, do you have a tight iliotibial band? You can test for that and see if they have tenderness right at the side of the lateral knee where you get a lot of bending. Most of the time that's the iliotibial band rubbing. So anatomy, I'm just going to go through this really quickly. We all know that it operates as a hinge joint. You got the tibia, the fibula, the femur, and the patella are the big players of the knee. You got the menisci and the ligaments. These are mainly to restrict a lot of excess motion, and you got the anterior posterior, so that'll be your ACL and PCL. and then medial and lateral, which will be our MCL and LCL, and then rotation. So everything kind of works in concert to stop rotation, but you gotta think about the meniscus helps with a smooth rotation, but also meniscus can get caught, and that's how it gets torn for rotational issues. Here's a nice picture of the knee. So we got our tibial tuberosity, and this is where Osgood-Schlatter's happens. If you grow really fast, the patellar tendon pulls a lot at the tibial tuberosity and causes an irritation of that growth plate. SLJ is where it comes up here at the patella. You can pull up there also. They'll have pain right here on the border. You got your lateral meniscus, your medial meniscus, your MCL, and your LCL. And in the center of your ACL and PCL. So those are our big players. We got our patella. And here's a nice inside picture, your ACL and your PCL. So let's just talk a little bit more in depth about the anatomy, the menisci. So they're two semilunar fibrocartilage discs. They provide cushion and motion between the femur and the tibia. The medial one is more C-shaped, and the more important thing is it is the more injured meniscus. No, more often than not, if people come in with a meniscal injury, it's your medial than your lateral. And basically the reason that is because we, first of all, hold more of our weight medially, and the medial meniscus is tethered a lot more to the knee, to certain structures. So it melds with the posterior medial capsule of the hamstring and the semimembranous muscle. It's attached to the deep portion of the MCL. It's attached in the whole outer capsule of the joint capsule. So it is really held in place. So when you're twisting on your knee, the lateral meniscus gets to twist with the bones. So it moves a lot more. The medial meniscus is very tethered. So when you twist on your knee, you get a lot more shear force across that meniscus by the femur and the tibia. And that pinching and shear force is why it gets torn more. Lateral meniscus, like I said, it's a lot looser attachment to the joint capsule. It's not attached to the LCL at all. It just has a small puny attachment to the PCL. So it has a lot more ability to zig and zag as you rotate back and forth on the knee. Don't forget that the vascularity of the meniscus changes drastically. When you're born, you do not have 100% vascularity. And as you get older, it goes lower and lower, which means two things. One, it's harder to heal itself. So if you have a 15-year-old that tears their meniscus, not only is it harder for them to tear it because it is stronger because it has that vascular feeding to the meniscus, but if they do tear it, sometimes the surgeons will suture it because they have a higher ability to heal it and actually get it to knit back together because it does have the vascularity. As you get older, it becomes a lot more fragile because it doesn't have as much blood supply. So the shear force against it from like someone deep knee bending. I had a woman do it bending to get the clothes out of the dryer. I had a man do it trying to clean his grill. You know, you do a deep knee bend, you do a shear force against that meniscus, you can tear it. And it often won't heal on its own because it doesn't have a lot of vascularity. Now here's the other positive thing about being older. The one positive thing about being older is that if it's a small nick, you can buff it out, okay? Because it is a little bit more fragile. So just walking, sometimes I'll have people say, you know what, my knee hurt horribly about 4 months ago, and it's now about 75% better. It's slowly getting better. Chances are they had a small nick in their meniscus, but they're kind of buffing it out. It's like having a small nick in your nail and rubbing against some rough material. Eventually, you'll buff that nick out. So that's the kind of positive thing. But it does affect, you got to think about the vascularity as it gets poorer as you get older. And the ligaments. It's divided into 3 groups. You got to think about extracapsular, which is the LCL and the superficial MCL. Capsular, which means it melds with the actual capsule, which is the deep MCL. And then intracapsular, which is the ACL and PCL. The ACL, we all know, is a main stabilizer for anterior translation of the tibia, but it also does have some secondary stabilization for varus and valgus stressing and internal and external rotation. So there's a lot of movement in the knee that the ACL is kind of being a player with, which is why, you know, people can do it running down the field axially and stopping short. They can pop that ACL that way. They can stop and pivot fast. They can get a rotational force or a valgus stress to the knee. So a lot of different motions that can tear that ACL because it is such a big player in all of the motions of the knee. PCL, primary restraint to posterior translation, and secondary stable and external rotation. PCL is a little bit harder to tear, and often people can live very healthy, happy lives without their PCLs. There are people playing in the NFL without PCLs. ACL, you have to really think about, you know, what kind of stability they need. MCL has a superficial and a deep layer, so you can injure just the superficial, you can injure just the deep, or you can injure both. This is why when we go to stress it, we stress at 0 and 30 to 40 degrees of flexion because you want to stress both. So when you have the knee flexed at about 30 to 40 degrees and you're stressing the MCL or the LCL, you're really stressing, or sorry, the MCL, you're stressing the superficial. At 0 degrees, you're stressing the deep. And then the LCL, the poor LCL, it alone is not very effective at all, really doesn't do very much. When you meld it with the popliteus tendon and the arcuate ligament, it can restrict some varus stressing, but it doesn't really, it rarely gets injured, and it doesn't have a very much effect in the movement of the knee. So history, nothing, as with anything, replaces a good history in physical. You have to ask lots of questions. You want to know the type of activity that they were doing when they got injured, the position of the knee or the leg or the foot at the time of the injury, the mechanism of injury. Was it a direct blow? Was it a fall? Did somebody run into them? Did they misstep? Did they twist? What happened? You want to ask if it was a sport, what surface were they playing on? AstroTurf has been great because it is easier to maintain the field, but it has a lot more friction, so these kids are getting a lot more injuries to their knee and ankles. Was there a pop, snap? You know, did they hear something? Did they feel something? Where does it hurt? Is there any locking, catching, giving way post-injury? Was there a fusion? Did it blow up right away? Or was it just a little bit, or did it not do anything at all? If someone says to you, I think I tore my ACL, and you ask them, did they have swelling? And they say, no swelling whatsoever. 99.99999% chance there was no type of ACL tear, because that would cause massive swelling and hemarthrosis. There'd be blood in the joint also from that tear. So you always want to ask about a fusion, because it'll kind of tell you, was there something that was significant that happened inside the knee? Ask where the swelling was. If it's full joint inside the knee, then you're thinking about meniscus, ACL, PCL. Maybe bang the two bones together, they have bone bruise or arthritis, irritation. Were they able to finish the activity? That's a big thing. You know, hey, yeah, I felt a snap, I shook it off, but I played the next 3 games of volleyball. And chances are they didn't tear their ACL if they did something like that. And then always ask, was this knee previously injured, or the other knee? Because you got to remember, if I'm testing the ACL and doing a Lockman's, and I'm testing the good leg, and you find out they had that one repaired, then you don't have anything to compare to. So always ask about, you know, did this knee ever have an injury? Did you ever have a repair of this knee also? Because that's your gold standard. That's their normal, quote unquote, normal side. So you want to know, is it actually normal? Did they have any type of surgery on it or anything like that? So let's talk about some cases. So the first case, 13-year-old soccer player presents to the office. This player was running down the field and was pushed by an opponent. He landed on his right knee and felt immediate pain. So kind of pushed forward and landed directly on the knee. When the player was on the floor, on the field, the knee was hyperflexed, and the trainer arrived and straightened her leg for the examination. And when the trainer straightened her leg, they felt a pop. Okay? Immediate sharp pain, and then there was an effusion. Okay. The effusion, though, was not full knee. It was mostly around the anterior knee. It didn't extend over to the medial and lateral, so that's important. She was able to only bear minimal weight limping off the field with the trainer. In the office, she's very, very, very tender along the medial patella and had a significant effusion. So we want to review some facts. She hurts on the anterior knee. She had an acute trauma to the anterior knee. So we're thinking about that list of what we started with of what's going on in the anterior knee. She doesn't have full knee swelling. So probably not something intracapsular. So not her ACL, not her meniscus, not a bone bruise. She's too young for arthritis, hopefully. So we're talking about something anteriorly, but extracapsular. So most likely, she either subluxed or dislocated her patella. So she felt a pop. Often the kneecap will go out, and 9 times out of 10, a patella dislocates laterally. In order to dislocate laterally, you have to tear the medial retinaculum, the tether that holds the kneecap in the center of the knee. So as you go laterally, you rip that medial retinaculum. That's why they have so much tenderness along the medial edge of the patella, okay, because they ripped that retinaculum. Patella dislocation or subluxation can occur with or without trauma, though. Some people have really bad congenital orthopedics. They're born with what I call PPP, piss poor protoplasm. You'll hear me say that all the time. I'm like, oh, it's unfortunate. They have PPP, they have piss poor protoplasm. So they might have a really shallow notch. Their kneecap, the back of their kneecap might not have a nice pie-shaped V. It might be very flattened. And see, that's not going to stay in the joint very. So if they twist wrong or if they get a stress to the knee, it can go out on its own, unfortunately. A lot of times happens with trauma, though. Kid falls and just hits that side of the knee just right, especially if it's a girl, so they have an increased Q angle. She's 13, she's going through puberty, her hips are widening, so those are all kind of setups. She's beginning to get maybe some estrogen surges, her ligaments are getting a little more relaxed. So this is all kind of a little bit of a perfect storm here. Spontaneous reduction is very common. When you straighten the knee, often that pops that kneecap back in. So a lot of times people are so surprised that it happened, they straighten the knee right away and they do it themselves. On exam, they usually have some diffuse effusion anteriorly around the kneecap. They have tender depalpation of the medial retinaculum. Sometimes the lateral trochlea, because as you go out, you bang that lateral side of the kneecap over the femoral condyle, so it'll be very tender laterally also. And often they're very apprehensive. They do not want you to move that kneecap around at all because they're very concerned that you're going to pop it out again. And patella load testing is positive, which means I take the kneecap and I just push on it directly down and make it kiss the femur. They are not very happy with that because they obviously have smacked the back of the kneecap, rubbed it really badly, and so they're very irritated there. So this is a nice depiction of the apprehension test. So this is the lateral side of the knee. Here's the medial. You can see the fibula here. You're going to push the patella laterally, so into the area of dislocation. First of all, they're going to be very worried that you're going to dislocate it, so they'll usually pop up or they'll grab your hand. Second, as you go to push the kneecap laterally, you're kissing that bone. That's going to hurt a lot. And you can see the thumb is along the medial retinaculum. That's also going to hurt. When you can get x-rays, AP lateral, sunrise. Always remember, you always want to do your APs if they can stand. Weight bearing. Never order a knee x-ray if your patient can stand on a AP or PA without having them being weight bearing, especially if they're 25 and older, because we want to evaluate for how their joint space is. Everybody looks good lying down, okay? But if you send me a 400-pound patient and you x-rayed them lying down and their joint spaces look, I don't know what happens when they stand up. Most likely they smash down because 400 pounds, remember, they're probably about, I don't want to do the math, 300 pounds, 3 to 250 overweight, 250 times 4, it's a lot of weight of pressure on that knee. So always do that weight bearing. So sometimes you see some dislocation, sometimes you might see a little chip fracture, but most of the times you don't see anything. This is an x-ray of the kneecap being dislocated. Usually we don't see that. They usually reduce before we actually get to x-ray. So how do we treat it? Well, first we want to always go into our activation mode of just trying to quiet everything down. So we do RICE, rest, ice, compression, elevation for about 24 to 72 hours. You can brace them for comfort. I do not like to ever brace the knee for any long period of time if possible, because you don't want to have it get stiff. If they need something to kind of hug and support the kneecap, you do it for about 1 to 3 weeks, but I don't like to do it usually for more than a week. Then you want to send them to physical therapy. You want to do quadriceps strengthening, especially the vastus medialis obliquus, which is the inside section of the quad. The medial section of the quad is what is usually weak and allows that kneecap to drift even more laterally. So you got a woman with an increased Q angle coming in at their knees at a sharp angle. Their kneecaps are already set out. You want to make sure that you're not setting them up for more dislocation. You want to strengthen the VMO and pull them further in. Okay, you want to medially load that kneecap. And then role of surgery. Some of these kids have such bad orthopedics that they can't stay in. They're constantly dislocating. Every time you dislocate, you whack the back of that kneecap, you're setting yourself for severe premature arthritis. So these kids sometimes do need surgery. It's very, very rarely. So sometimes they'll do a medial retinaculum repair. They'll really sew up the medial retinaculum. But a lot of them, they need to correct the orthopedics. So what they'll do is they'll cut the lateral retinaculum. If you cut it, then maybe you can snap that kneecap more medially. Or, more common thing that I see, they actually take out the tibial tuberosity and move it over and plug it back in. So they move the whole kneecap over. It's called a tibial tubercle transfer.
Can you explain the VMO angle for...
They
might not know
the Q
that.
angle.
The Q angle is with the hips, the knees.
That is coming up.
Oh, okay, good. Thanks.
See.
Yeah, that's okay. I see it on another slide.
We got Q
Okay.
angle coming up.
Thank you.
Okay. So patellar femoral syndrome, the most common thing that comes into my office for the teenagers to 30, especially women, very, very common, a lot of knee pain. It's called patellar femoral syndrome, also known as chondromalacia of the patella. Usually coming in, people just say they have a lot of anterior knee pain. A lot of times it's due to malalignment. They have an increased Q angle. Same thing we were talking about the patellar dislocation. I'll talk about that. Your kneecap widens, or your hips are widening, and you come into your knee at a much sharper angle. Men come up at their knee at a much more axial angle. Okay, and sometimes you look at these patients and their femurs, their kneecaps are pointing inwards, so their kneecaps are rotated in. Maybe they have really, really flat feet. If you have really flat feet, that causes the kneecaps to rotate out. So take a look at your home patient. If you have a flat-footed patient and they're having a lot of knee pain, sometimes the best thing you can do is give them some, I always send them to some Dr. Scholl's first. Just because sometimes people really hate orthotics, and custom-made orthotics are extremely expensive. So I say, go find one of those plates. Go stand on the plate, find out what number you are. A lot of times if you are really a pronator and a flat-footed person, they'll give you an orthotic that will kind of straighten you out. When you straighten you out, it straightens the whole leg out, and then the kneecap gets centered. So don't forget to look at the foot. A lot of times it's an overuse injury, so a lot of repetitive bending and rubbing going on to the back of the kneecap because it's malaligned. But sometimes it can be acute. I had a woman who had bilateral patellar femoral syndrome, a very nasty case. She tripped on a crack on the sidewalk and just fell forward and socked the kneecap into the femoral groove on both knees and really irritated it a lot. So what predisposes you to patellar femoral syndrome? We already talked about this with the patellar femoral subluxation or dislocation. VMO weakness, first thing. Got weak inside quad, you're going to let that kneecap drift out. If you have the other side, the VML, so that's the lateral side, if you have hypertrophy of that, it's really tight, that can cause it to drift out. You have a high and lateral patellar posture, so some people's kneecaps are high riding. If you're high riding, you're not very well set in that groove, so it can rub a lot. Increased Q angle, which we'll go over, and then bony deformity. Some people have a very shallow femoral notch, sometimes just the way they are put together, they're gonna cause more rubbing. Pes planus, that's flat feet. So if you're flat-footed, that's gonna make the kneecaps drift out. If they're knock-kneed, some people are born knock-kneed. So some people are knock-kneed because their feet are very flat. Some people have arches, but they are knock-kneed. It just depends how God puts you together. So look at the legs and then tibial internal rotation. So if someone's pigeon-toed, flat-footed, and knock-kneed, their kneecaps, I would be surprised if they didn't hurt. That's just very bad orthopedics. So when they come in, they always say they have anterior knee pain. They often have worse pain with sitting in tight spaces. So that used to be called, it's called the theater sign because people never wanted to go to the theater. Because the seats in front of them, they couldn't kick out their knees. They were trapped with their knees at 90 degrees. That 90 degrees trapment causes a resting pressure of the kneecap against the bone. You got an irritated back of the kneecap. That's gonna cause an increased pressure. They're gonna describe this. I always ask, do you ever sit back of a car, plane? Do you fear things, those kind of situations, and you feel like you get this ache that builds and builds and builds and builds, and it feels so good to kick out your knee? And they'll say, yeah, I do. That's a theater sign. That is when you kick out the leg, the kneecap pops up and you clear the space there, you clear that pressure feeling. Very common symptom in patellofemoral. So if you think that a patient has patellofemoral, ask them about that. Do you have trouble sitting with your knees tucked underneath you for long periods of time? Do you get a pressure that builds and builds and builds, and it really feels good to kick out your leg? Do you feel like you're very restless all the time? Are you always straightening out your legs, trying to relieve some of that ache that you get in the front of the knee? They say, yeah, that's patellofemoral syndrome. Often worse going up and down stairs or up and down slopes, because that pulls that kneecap in as you're going up and down, activating the quad. Every once in a while you might see a mild effusion right around the kneecap. I rarely see that. It's more just irritation. Sometimes they will say, I haven't had an increase in snap, crackle, pop, some grinding feeling. That's because you get a layer of fluid on the back of the kneecap. I always tell them it's like having a pair of dry socks and skating on a parquet floor, how smooth it is. Now try to do that with a pair of wet socks. You're going to stutter. I say it's the same thing as the kneecap, is that we can't glide through the groove really nicely if you have a layer of fluid on the back of the kneecap. It's going to stutter a little bit. So they might complain of just increased grinding. My knee is more noisy. People are complaining about my knee. It makes snapping and popping when they're walking next to me in the stairway. And they sometimes will say their knee is locked. The word locked is a very dangerous word. Locking means something got stuck in the joint. People use it all the time, but 9 times out of 10, when I really vet them, it is not locking. It's severe stiffness. And the kneecap, if I sit for a long time and I bat patellofemoral and I sit with my knee tucked underneath me, with the kneecap kissing that bone, it usually sticks a little bit. So when they go to stand up, they feel like it, and then it lets go and it jumps. So it feels like it unlocks. That is common for patellofemoral. So on exam, they usually have pain when you compress the kneecap into the femoral groove, so patellofemoral compression. When you go to bend their knee back and forth, I usually put my knee on top of their kneecap. You feel that nice snap, crackle, pop of crepitus. It was really, some people have some impressive crepitus. They usually have tentative palpation of the posterior edges of the patella. So if you dig on the medial lateral posterior edges, they don't like that because that's where a lot of rubbing happens. They usually have a lot of tenderness of the fat pad. Sometimes my residents, because the fat pad is right here at the joint line, they'll be like, oh, I think they have a meniscal tear because they have joint line tenderness to palpation. I'll ask where? And it's way in the front by the patellar tendon. You can't tear your meniscus up there. You don't have any shear force. There's no way to pinch it. There's no way to, it's be in a catastrophic accident and dislocate your knee to tear your meniscus anteriorly. It's usually irritation of the kneecap or the patellar tendon that causes pain of the fat pad. So they hurt in that whole area. Sometimes they'll have what's called a J sign. So when you go to bend their knee back and forth and you're feeling the tracking, it doesn't glide back and forth nicely. Sometimes all of a sudden it'll do a little jog. It'll do a little J. So that tells you that when they're walking back and forth, when they're going up and down the stairs, that kneecap is not going back and forth. It's going a little bit, it takes a little detour. When it takes a little detour, it rubs. And that rubbing, that's a problem. You got to correct the J sign. Imaging, most of the time is normal. But you want to get at least the merchant view, which is this, or also called the sunrise view. So you can see this kneecap is drifting laterally. There's a lot of rubbing going on here. More on the left than the right, but you can see there's a nice tilt there. And you can imagine that this is getting a lot of rubbing, a lot of irritation. It does not fit nicely like a puzzle piece in this femoral groove. So treatment, rehab. Biggest thing, you need to get their mechanics corrected. So VMO stretching and strengthening, so you want to get that kneecap to be pulled medially. NSAIDs, I sometimes will do a very short burst, maybe like 10 days, 3 pills, 3 times a day. I almost tell them, pretend you have strep throat. You want to get rid of this inflammation, you got to take a steady dose for 10 days. I don't like to do long term, and always make sure you remind them about their stomach. Ask them if any stomach problems, and tell them if they have any irritation, they got to stop taking it, and they got to take it with food. Ice is always good. Having the physical therapist teach them some taping techniques. This day and age, everybody can get their hands on some kinesio tape. It's sold in Walgreens. You can tape a lot of times the patient, if you tape that medial side, the lateral side to push the kneecap medially, a lot of times I give them a lot of pain relief, and you can offset that rubbing. And if you do that for a couple weeks, you can really calm down the back of the kneecap while you're strengthening the VMO so you can correct it completely. Orthotics, we talked about this. You want to correct that foot malalignment. Giving people the chance to pull up that arch will often will get them to realign and give a little bit. Surgery, very, very last resort. It's kind of in the realm of patellar dislocation and subluxation. So patellar issues, you want to look at evaluated in your office. You want to evaluate what's called the Q angle. You measure the Q angle by drawing 2 lines. Line number 1 goes from your anterior superior iliac spine, and you're going to the mid patella. So you can see here on this picture, from the anterior superior iliac spine, we're drawing a line down to the middle of the patella. Line 2 goes from the middle of the patella through the tibial tuberosity. So it's a very short line. You go from the middle of the patella through the tibial tuberosity, draw a line up. In between these 2 lines is your Q angle. Angles above 15 degrees are high Q angles. Women often have Q angles 15, 20, 12, those are high numbers. Men usually have Q angles around 8, 10, so it's not as high. They're high risk for patellofemoral, they're high risk for subluxation. And then always check to see, some people are really loosey-goosey. If you're really loosey-goosey and you can get a huge glide back and forth of that kneecap, just imagine when they're doing their daily living, they're chasing their 3-year-old, they're doing some twisting, that kneecap is all over the place. So you want to really make sure they do some physical therapy and tighten up all the muscles around the kneecap so they have a good corset controlling that. And then, as always, look for foot pronation. Okay, case 2. So we have a 16-year-old female soccer player. She planted her right leg, and then she shot across her body with her left leg in an attempt to goal. So we're planting our right foot, and we're doing a big shear force twist. She felt pop and a pain, but she got right back up, and she jogged down the field, okay? So it wasn't enough to ground her. She got up, walked down. But when she was walking, or when she was running down the field, something didn't feel right. The knee felt very loose, so she signaled to the coach that she needed to come out of the game. When she got to the training table, the knee had already begun to show significant generalized effusion. Okay? So the knee began to blow up. immediately. And a 16-year-old, until proven otherwise, that means she did something traumatic to the inside of her knee. She might have had a bone bruise, she might have torn her meniscus, she might have torn her ACL, something like that. So we had a high shear force twist. She felt a pop. She was able to walk on it, but it felt very loose, and then she had an effusion. So now we got to think about what is inside the knee. What do we think is going on? So we talk about ACL injury. So she popped her ACL. It's one of the most common disabling injuries of the knee and the most dreaded injury for the athlete. 1 in 1,500 knee injuries, and 70% are sports related. Can occur with or without contact. This girl was not jostled at all. She did this to herself. She's planted and twisted. Sometimes though, you're coming on down, someone clips you or something, you can have it be a traumatic or a contact injury. It's usually associated with a deacceleration, rotational force, or a hyperextension. Sometimes I'll have somebody running really fast on the field and they'll stop short and they'll hyperextend that knee and pop it that way. It's often associated with other injuries, so don't forget that it's very common to injure your MCL and the menisci. And a lot of times, especially for women, it's due to an inequality in how they contract their quadriceps and their hamstrings. So they often pop it that way. We have an ACL training program, which has been, it's been across the entire country, and we've seen a huge reduction in female ACL tears because we've been training them how to control the motion of their knee and how to contract things evenly. So, history. They usually have an acute injury. Patients say they heard a pop or tearing. Sometimes they say the knee felt loose or feel like it's going to give out on them. They can't trust it. They usually have swelling immediately, but sometimes it can happen within the first 12 hours. And they usually give what's called the two-fisted sign. So they take their two fists and they say, it just feels loose. It feels like the bones are shifting around. So that's a common thing when they go to describe it to the office. I've had people do it all the time, and it kind of makes me smile. It makes you smile when something that you read in the book actually happens in the office. But they'll give the two-fisted sign and say, it just feels loose, doc, and they'll shift their two fists back and forth. Chronic injury. So you can have an acute ACL tear, or you can have an instability issue on a chronic injury. Okay, so people come in with a chronic ACL, they'll just say all of a sudden it feels loose. I'm having some instability. It's going out on me. They'll also give you the two-fisted sign. The biggest thing I always tell my residents. Someone comes in with a very, very, very good story for an ACL tear. You get the MRI. You look at the MRI, or you get the report. You look at the report. The number one thing you want to see on that report, besides the words ACL complete tear, is if there is a bone bruise, okay? The acute tearing of an ACL is a violent dislocation of that tibia on that femur to tear that. So it's a smashing of those two bones. You will have a bone bruise, okay? 99% of the time, if you don't have a bone bruise, then you have to start asking them questions about their history. Because what I find is this was not the time they tore their ACL. If you go and get that MRI and it says complete tear of the ACL, but there's no mention of a bone bruise or any fluid in the bone, something like that, bleeding in the bone, that usually means they tore it some other time. And I find out, oh yeah, when I was in high school, senior game, got clipped, came out, swelled up. My parents told me to throw some dirt on it. I iced it for a couple of weeks, slowly got better. I went to college, never played, picked up running. Beautiful axial thing that does not cause any stress on the ACL, running on treadmill, running. They never had any problem. Now they're playing around with their 3-year-old, tearing around in the backyard, and they did a twisting motion, knee goes out, they fall down. That is an instability incident. It's not as violent because they have nothing to rip. It shifts, they fall, and they then won't have a bone bruise. So always look for the bone bruise in the impression on the MRI along with the ACL, because that often tells you, did that happen when they said it happened, or did they have something in their past? Okay. So physical exam, they usually, because of all the swelling, they have very limited flexion. I like the Lockman's test is the best, has the best sensitivity and specificity. Pivot shift, very hard thing to do. I rarely do a pivot shift testing. Anterior drawer, I use it along with my Lockman's. You gotta imagine when you're doing an anterior drawer, that patient is shifting up and down the table with you as you're tugging their knee, so it's very hard to feel if the tibia is shifting with you. So Lockman's and the Story are my two favorite things to kind of do, whether I'm gonna do an MRI or not. And don't forget, always, there can be associated injuries. Do not forget about that. X-rays, usually normal, but there are two things you don't wanna miss. One is called a Sagan fracture, which is when you actually, when you go to shift, you actually pull on that lateral posterior capsule and you pull a piece of the bone off. And then a tibial spine avulsion. So those are two things that you can see on X-ray. The diagnostic study that you're going to want to do is an MRI. Okay, 90% accuracy rate, very good. I think it's even higher now. MRIs have really gotten good. Good for identifying the associated injuries, your meniscal tears, things like that, bony contusions. And just, I couldn't stress enough, everyone should suspect an ACL injury if you have an acutely swollen knee after an episode of giving way, twisting, or hyperextension, especially if they say they felt a pop. That is the first thing that should pop into your head, okay? So here's the Sagan fracture. You can see this little sliver. It's an avulsion fracture on this lateral posterior edge, and here's the tibial spine fracture, okay? So those are two things that you could just see on X-ray. Treatment, I usually, as usual, do rice. You want to calm it down, try to minimize the swelling. Referral, not every ACL needs surgical repair. Some people do very well with physical therapy, tightening up the knee, and then being like, you know what, I like to run. I don't need to. I was just doing a charity soccer game, reliving my glory days. I don't need to do that. You got to remember, an ACL surgery is a very, very involved surgery, and some people are not zoned for it, okay? They have to follow up, they have to do extensive physical therapy, all that kind of stuff. So evaluate your patients. Some of them are not good candidates. So when you need to get surgical repair, if they're gonna be playing a sport that has a lot of axial loading, twisting, changing direction, chances are they're not gonna be able to do that without having a good ACL. So they're gonna need that. So if you have a college athlete that plays, college soccer, their scholarship route depends on it. They're gonna get their ACL fixed. They're having symptoms of instability. They can't trust it. Every time they pivot on it or something like that, it feels like it's going out. You gotta be careful. Every time that bone shifts, it kisses the femur, and you're causing premature arthritis setup. So you need to make sure that if they're saying it feels loose, they can't trust it, it feels like it's slipping around in there, and it's, every time it slips around, they're getting a little bit of swelling, they're having instability and they're causing damage to that joint. They need to have that fixed. I had a woman who tore her ACL in high school. And she did great until her 40s, and she had she was just fooling around in the kitchen doing ballet moves. Someone lifted her up, she landed and planted, and it went out on her. And ever since it went out, then she began to have chronic instability, and then she got it fixed. So people can do very well without it. Okay, case 3. We have an 18-year-old female basketball player. She comes in with a complaint of left knee pain and a fusion. Okay. So we'll get to see where the effusion is in a minute. She was making a run for the basket, and while attempting to guard the ball, she was kind of jostled and she had a forced twist on her left leg. She felt sharp pain in the medial knee, but she continued to play. At halftime, she complained to the coach about tightness in the knee. sharp pain with landing on the knee. So she had tightness in the knee, so the capsule was swollen. Okay, so the entire capsule. So now we're thinking about intracapsular. She went to her urgent care and she got some pre-clinic x-rays. Looked good, no problem. So she has a medial meniscal tear. Okay, so she had a twist, she got jostled, she had a forced twist on her meniscus. It's the most common referred knee injury in the USA. Okay, 1 in 1,000, so more common than your ACL. 50% of the time, though, it is associated with an ACL. Those two are friends, they go together. It commonly tears posteriorly. That posterior horn, medial meniscus, is the money shot place. And that's just because there's a lot of shear force going on and we carry most of our weight medially, and that's where it is severely tethered. There is not a lot of play that posterior meniscus can do. There's two types, traumatic. So this young woman had a traumatic one, someone clipped her. And there's degenerative, that's the older population, where I was minding my own business, I did a deep knee bend or I twisted on it, and then I began to have sharp pain in the medial joint line, swelling, things like that. Common mechanism of injury, though, is twisting on a flexed, loaded knee. Hyperflexion is also a common one, or in the older population, they often say, I have no clue what I did. Because you know what, they were just doing their daily activities. You know, they were doing the laundry, they were picking up their husband's socks, they were doing something and they deep knee bend and something happened. Nothing out of the ordinary and they have no idea. So I often get that. History, they come in with joint line pain. So we're talking about pretty distinct. They do not say they hurt medially, anterior, laterally. They might have a meniscal tear, but if they also have extremely generalized pain, and they're an older patient, most likely it's arthritis. This is a younger patient. Joint line pain, catching, popping, locking. Now here comes the word locking. People use locking a lot for severe stiffness, like we were talking about patellar subluxation. Locking for the meniscus usually means that there's a large tear and it's flipping up and getting stuck in the joint. So when I ask them about locking, I always ask them, is it like you're minding your own business and all of a sudden the knee gets stuck? Like God removed your joint and you cannot move it an inch that way or an inch back. You cannot flex extend and you gotta wiggle it around a little bit and then all of a sudden it lets go. That is true locking. It is a pebble in your gear. It is a mechanical blockage. People who have knee injuries often get very stiff when they sit down and they begin to stand up and they're like, my knee locks on me because it takes forever for me to straighten it out. That's not locking. That's severe stiffness. So when someone says locking, you have got to ask them a lot more questions, make sure it's true locking. Because you say locking on your exam and you're sending them to ortho, that you're telling them that you think that they have a mechanical block, a loose body, a meniscal tear that's causing a bucket handle. They often have difficulty squatting. That's usually because of the effusion and also because it's shear forces on the tear. That usually causes a lot of pain. Physical finding. When you poke on that joint line, they usually give you the look like they want to smack you. They usually have an effusion. Pain with passive flexion. They really don't like you to flex. Some of that is squeezing on the capsule because it's so swollen. That hurts a lot. They usually have what are two tests for the meniscus. The McMurray's, which is where we're going to pinch the meniscus between the tibia and the fibula and grind on it. And the Apley's test, where I have them lie on the stomach. And literally, you bend their knee up to 90 degrees. You smash down on their knee like a plunger, and you twist. So you're loading and twisting. And then they usually have loss. They sometimes will have loss of extension, or if it's really bad, they'll have locking during exam. I've only ever had locking once during an exam. It scared me to death. But it usually doesn't happen. But if it does, send them for their MRI, give them a pair of crutches, and send them. That is an orthopedic emergency. So these are two pictures depicting the McMurray's test and the Apley's test. So in the McMurray's test, you're going to do a valgus stress. Sorry, this is a varus stress. A varus stress, so you're closing down the medial meniscus. on the medial meniscus and you're rotating around on it. So you're just basically trying to pinch the meniscus between the two bones and twisting. We can do a whole taping of the exam, but the big thing is you need to practice it. So when you do your rotations, if you're with an orthopedic surgeon or a primary care that does a lot of sports medicine, or have them practice that. And I do most of my meniscal testing and my ACL testing. I love to do them on my kids when I'm doing well child. The kid is so relaxed, and when they're lying down on the table, you want to check the movement of their joints. All of a sudden, do a Lockman on them. Do a little McMurray's. They're so nice and tiny. You can get your whole hand around them and everything, and they're just loosey goosey. So practice on the kids when you're doing well child. Athlete's test. This is what I was talking about. You push down, like you're on a plunger. So you're loading and pinching the meniscus between the tibia and the femur, and then you're just screwing the knee in and out. This is a reverse athlete's. They should feel better, because you're distracting the joint and twisting. You're no longer grinding it. So you grind it, they yell at you, and then so you pull the knee up and then do the same thing. They should say that feels better. So diagnostic testing, just like an ACL, usually normal for x-rays. But you want to evaluate them. Do they have some arthritis in there that you don't know about in the older population? MRI, it's the best thing, just like an ACL. It's very sensitive, very specific. Treatment, I usually give them rice. If they are in a lot of pain, can't weight bear, or they're having trouble with locking, I'll give them a pair of crutches so they can weight bear as tolerated. That's what WBAT means, weight bearing as tolerated. Some degenerative tears can, like I said, they can buff them out. A few of very small traumatic tears, if they're a younger population, sometimes they can fix themselves. They can kind of heal because they have good blood supply. All of those others are referred for arthroscopy, which is the most common thing that happens. All right, case 4. We got a 14-year-old soccer player who presents the office with a complaint of right medial knee pain. So just like the basketball player, they both have right medial knee pain. States that he was vying for the ball and his opponent slammed into him. They both fell to the ground, and he had immediate medial knee pain and swelling. So his swelling is medially. His pain is medially. So we got to think about what is medially. Our medial meniscus, our MCL, a piece of our hamstring, our pes anserine bursa over there. So, but it's medial swelling. It's not generalized. So that kind of crosses, that moves my medial meniscus further down the list and moves up things that are extracapsular, which would be our MCL. He's using crutches due to pain, which has gotten worse over the past couple days. So we're going to talk about MCL and LCL sprains. He has an MCL sprain. MCL sprains are very common, but always remember it can be associated with other injuries. It usually involves a valgus stress. So somebody hits you on the outside of your knee, pushes the knee inward, and just stretches the heck out of the medial collateral ligament. It has a high potential for healing. MCL is rarely ever fixed, but it can hurt unbelievably bad. These patients, it's a little bit of the bane. I have a list of bane of my existence, and this is on the list of bane of my existence, because they hurt. If you got a bad MCL, sometimes for months and months and months and months, they're frustrated, and then they're frustrated at you because you can't fix them, but they don't understand that this ligament just needs to heal. LCL. Very uncommon, because someone has to get in between your knees and push outward. It's a very awkward mechanism of action. Rarely happens. Usually it's in soccer when someone's, two people are vying for a ball, but it rarely happens. So you get this varus stress. The LCL, though, usually tears completely, and we often fix it. It's very uncommon, though. History, they usually have the varus stress for MCL, valgus stress for MCL, and varus stress for LCL. They usually feel a pop. They will have edema just over where the ligament is, and they feel like, sometimes they'll say it feels like the joint opened up. And that's because they stretched the heck out of the ligament and the joint actually kind of bent open. Physical exam, they're extremely tender over the ligament. And they have usually have pain when you stress it, and sometimes some laxity because they've torn it. They've done some macro and micro tearing of it. Don't forget the MCL is also associated with ACL. They're in that gang, a group of ACL, medial meniscus, MCL. They all like to hang out together and get hurt together. So we grade MCL and LCL sprains as grade 1, grade 2, grade 3. Grade 1 is a minor strain. So they have microscopic injury to the ligament. They have tenderness along the collateral ligament. They don't have any laxity. The ligament's still extremely tight, but it's just tender, okay? Grade 2, they have partial macroscopic tearing. They have increased laxity. So they have some tearing and some breakdown of the ligament. So you're able to stretch a little bit more and it feels a little bit more lax. And the endpoint is extremely painful because they have more tearing of the substance of the ligament. Grade 3, complete tear. You have gross laxity. Sometimes when I go to varus stress, I can almost open them up like a screen door. You can really pull that joint open. But here's the thing. All of their fibers are torn. So they often have less pain than you would expect when you go to test them than a grade 2. Because the grade 2, you're still tugging on a lot of the fibers. Grade 3, it's completely blown out and you have a lot of laxity but less pain than you would expect. Diagnostic testing, x-rays as usual, usually normal. MRI. Unless I suspect something else, like, I think the MCL, but he also is having some possible ACL or medial meniscus symptoms, I don't get an MRI for just a pure MCL. Because the thing is, it's not a surgical issue. You gotta remember, MRIs are pre-surgical things. They are not tests to get to find out, I wonder what's going on in the knee. You should be able to kind of make a list and get a good solid idea of what's going on in the knee by your history and your physical. The MRI is to support it and then send them to the surgeon, okay? So if I think they have a pure MCL sprain, I do not get an MRI. If I think they might have a medial meniscal tear or something else, then I do. So treatment, as usual, we have rice, NSAIDs. Sometimes giving them a knee brace is helpful. I use the knee brace mostly just to remind them they need to keep their knee in line with their foot. They let their knee fall in, which you'd be surprised, all day long. When we get tired, we let our knee float in. Every time you let your knee float medially, you are stressing the MCL. So I tell them it's like having a giant cut on your knuckle, and every time you go to let that knee drift in or you twist on it, you're bending that knuckle and popping the fibers back open. I said you're just delaying your thing. So a knee brace is sometimes very, very helpful to kind of make them remember about keeping their knee aligned with their foot. You do weight bearing as tolerated. So it's very, very painful. Sometimes I have people who will do crutches for a week or two and then go to one crutch and then go to none. It can be very painful. You want to get them into early rehabilitation. I usually, as soon as that they can walk on it, you want to get them a little bit, do some gentle range of motion and help, and advance as tolerated. As I said, you want to avoid the stressing of the ligament, so valgus or varus stressing. And then if they have an associated injury, you're going to refer them. So an ACL tear, medial meniscus. All right. Case 5. So we have a 17-year-old who presents to the office with a complaint of right greater than left anterior knee pain. So we're in the anterior knee again, so we got to think about a list over there. He had this knee pain about 9 months ago also. Exact same thing. And it resolved on its own about 8 to 10 weeks. Went away on its own, now it's back. And he's very frustrated because, now he's playing and it's interfering with his ability to play soccer. Pain was initially just with activity, so if he did a hard practice, now it hurts all the time. It hurts when he's sleeping, and it's a constant pain in the anterior knee. So we're thinking about what's going on. He's not having any swelling, so he didn't tear anything, he didn't have any trauma, anything like that. So what is going on with him? He's 17 years old, he's a male. That's a big growth time for men. Women, usually the growth plates are closed by 17. Men, we're getting into, 15, 17, sometimes 19 to 21 even for some of them. They still are doing giant spurts of growth. So he's in that area. So he's got Osgood-Schlatt's disease, which is a common childhood pain. We have growth plates as children all over our body. The most common places that walk into my office that they complain of hurting is their knee for Osgood-Schlatt's and the back of their heel for what's called Sever's disease, where the Achilles tendon pulls on that growth plate on the back of the heel. Horrible for dancers, soccer players, because they wear very tight shoes that go across the back of that heel. Osgood-Schlatt's, these kids do huge growth spurts, and their bone grows faster than their tendon can adjust it. And so what happens, it pulls on that growth plate, causes a lot of pain, a lot of inflammation, and then when it stretches out, it kind of goes away. So you see this cyclical pain up and down. That is classic for apophysitis. So etiology, like I said, mechanical stress and excessive tendon at the tibial apophysis. Occurs early in adolescence and often associated with growth spurts. It's more common in males than females, mainly because females with their estrogen surge, they're a little bit more pliable, just slightly than men. But it's not to say, girls can have Osgood-Schlatt's also. I have a lot of girls, my dancers, will have a lot of Sever's disease on the back of their heel. So don't just discount, if it's a female, they can't have it. But their estrogen, that's the one time that their estrogen a little bit more, it gives them a little bit more advanced over the men, because it just makes everything a little bit more malleable, okay? They can usually complain of pain directly over the tibial tuberosity. I mean, they point on it like it's a button. And sometimes the tibial tuberosity, if it's been pulled on a lot, it might be a little bit swollen, and they also get bone overgrowth. Remember, bone does not like to be stimulated. You whack it, you pull on it. It usually responds by growing a little bit. So sometimes I'll see men later on in life, they'll be 30, 40, they'll come in and they'll have a huge bump where the tibial tuberosity was. And I was like, you had Osgood-Schlatt's disease as a child. And they'll look at me like I'm like some kind of psychic. I'm like, no, you have classic tibial, enlarged tibial tuberosities. Exam, they do not like you to push on their tibial tuberosity. Sometimes they'll have a high riding kneecap, which sometimes if you have a high riding kneecap, that even puts more stress on the patellar tendon, so it sets you up for a higher rate of Osgood-Schlatt's. Tight hamstrings, tight Achilles, tight quads. These kids are extremely tight because they're growing and they're not stretching properly. So imaging, you might see an large and irregularity of the tibial tuberosity. So you can see here the growth plate is getting pulled up. You're getting some bone overgrowth here. Okay. You can see some little chunks of bone here. And then here, you can see his right knee tibial tuberosity is very prominent. Okay, right there. So the sign of Osgood-Schlatt's disease later on in life. Sometimes you have some loose ossicles, but sometimes you don't see anything, okay? Just depends how long. Treatment. So you want some functional rehab programs, you want to stretch everything out, try to manage it, you do a lot of ice, a lot of Enzyme. I love the Showpat strap. So you can get this anywhere, okay? It's a strap that comes across the patellar tendon, and it kind of, when your kneecap and your quad is contracting, you're running around the field like a lunatic, it stops the pulling at the tibial tuberosity and kind of supports the patellar tendon. So it kind of gives children a lot of comfort. So I use the Showpat strap. My girls make the Showpat straps a lot with their pre-wrap. They'll wrap it around their knee in a loop and then tie it real tight over the patellar tendon. But you Google Showpat strap. I have, patients buy it off Amazon all the time. For the children, it's hard to get that in the store. If you're dealing with an adult who's having patellar tendonitis, or maybe not an adult, but like a late teenager that has an adult sized leg, you can get something like that in the Walgreens. If you're dealing with some of my dancers are really petite, they're not going to find one small enough for their knees, so you got to go online, and they do have child sizes online. Okay. So definitively though, you gotta talk to your patient, the cure is closure of the growth plates. So you gotta let them know, yeah, it sucks. This is the way your body, you are a person, some people are slow growers. They kind of just plod away. Some people do this huge burst and then nothing, huge burst. Those kids are the ones that get the apophysitis. You just gotta warn the parents that you are going to deal with the symptoms as they come on, okay? These people though, as you get older, if you're dealing with the adult population, they often have trouble kneeling on these. So I usually have them get a garden pad if they like to do lots of kneeling. If they have a lot of problem or a really prominent one, my favorite thing to do is to take 2 garden pads, have them kneel on one and trace where their knees are comfortably. Where do they like to kneel? Trace around, cut it out, and then tape the 2 pads together. So that when they kneel, they can put their knee in the hole and then it kind of drops down and just rubs a little bit on the second pad. So that's a kind of a thing that you can do for comfort. All right, case 6. So we have a 67-year-old male. He presents to your office with a complaint of generalized right knee pain. He is an avid runner. He was out for his usual 7-mile run that he does multiple times a week, but he began to notice pain that progressively got worse, okay? He got home, he noticed his knee was swollen and hurt to walk. This happens occasionally in the past, but usually resolves in about a day. Usually ices it, takes a little bit of NSAIDs, and it goes away on its own. He's in the office today though because his usual plan of action did not work. It's been over 7 days. It's been persisting. He wants to go back to running. He can't do it because it hurts. So he's in your office because he is upset. He wants to get back to running. So we got generalized swelling in a 67-year-old. So until proven otherwise, this is arthritis. So osteoarthritis, extremely common. 27 million Americans. 6 to 12% if you're greater than 30. 20 to 27% if you're greater than 55. As the baby boomers continue to age, it's going to just go higher and higher and higher. It's just joint breakdown. It's multifactorial. People are always like, why? How can we prevent it? Well, sometimes you can't really prevent the largest portion, which is the genetics. If you have piss poor protoplasm, just got to deal with it. Metabolic. Some people have, you got thyroid disease, you got diabetes, that affects your joint health. Biomechanical and cellular processes, the chondrocytes. So certain drugs sometimes will affect how your chondrocytes grow. Mechanical forces. Some people are knock-kneed. Some people are, they just have just the way they're biomechanically put together, they do more rubbing. And also if they're overweight. The American population, 2 out of 3 now are overweight. And this is causing huge stress over the joints. You gotta remember the knee is a joint that responds heavily to stress. Like I said in the beginning, 1 pound of body weight over is 4 pounds of pressure on the knee. So you get somebody who's overweight, they got bad genetics, and now they're 67, this is gonna be a bad scene. And the thing is now, ortho will not replace a knee if you're overweight. If your BMI is too high, they won't do it because you're gonna ruin the replacement. So then you have a population of people that are in a lot of pain. They can't exercise because they're in a lot of pain. So what do? So these are just some depictions. You can see the normal knee, the arthritis. You can see as you look on, most people close down medially, and as they close down and kiss, you gotta remember, bone does not like stress. So often, when we're young, our tibia is very rounded. It looks like a tulip bulb. It has this beautiful edging of roundness, okay? As we get older and more pressure from the femur on the tibia, the first thing that happens is you begin to see a much sharper angle of the tibia. So I say that, instead of going from a tulip bulb, it goes to a sharp edge of a corner to the patient. And then as more and more pressure happens, you begin to get some bone overgrowth. You get those little osteophytes. And when you get huge ones, it looks almost like a side view of a giant lips going on there. So you can see here, this is bone on bone. You're seeing some osteophyte overgrowth here. This is close down. There's some nice closing down, some bone overgrowth there. This is a lateral view. You can see a lot of rubbing. Your kneecap should look round like a small dinner roll. And as we get more pulling, often I see it turn more like a trapezoid. You get bone overgrowth as the patella tries to drag that patella through the groove, but the patella can't be dragged through the groove because there's too much arthritis between the patella and the femur. So what happens? The patella says, I'm going to get bigger, so I don't have to be pulled as far. So you begin to get bone overgrowth. So risk factors for osteoarthritis. Age is the biggest one. Females greater than males. Obesity, huge. Osteoporosis, I shouldn't say lack of osteoporosis. Osteoporosis is a risk factor for arthritis. Occupation. Did you spend your whole life as a construction worker? Were you a gymnastics coach? What was your sports activity? Did you tear your ACL as a child and you had a major insult to that knee? Did you have previous injury? Do you have muscle weakness? Do you have bad proprioception? So your balance is off. So you're constantly wiggling on that knee and kind of rubbing. No cure to date. So there is some interesting research going on with stem cell injections, other things like that. Treatment is focused on slowing the progression, controlling the pain, and improving function. All the evidence-based medicine shows the more active you can be, the better your quality of life and your pain will be. So you want to keep these people moving. Studies focus on pain, function, imaging. There's something called global assessment, which is a test you can give your patients just to see how bad it is affecting their activity of daily living. Treatment, we start very late. I always say there's this timeline. So I usually start over here with the ice, the physical therapy, the Tylenol, the NSAIDs. Got to be careful with the older population with the NSAIDs though. High cardiac risk, higher cardiac risk, not higher, higher cardiac risk if they, and also stomach. So you got to be careful with them. Watch their kidneys. Go to tramadol. I do not, and now opiates are not inappropriate at all. Be careful also with tramadol. Remember that tramadol is not a narcotic, but is what we call a narcotic mimetic, which means it tickles narcotic receptors. So if you have somebody who had a drug history, you do not want to use it. And also, if you have people who are super sensitive to narcotics, it often will trigger their reaction also. If you have people who get a lot of constipation or upset from narcotics, tramadol, because it does tickle the narcotic receptors. Even though it's not a pure narcotic, it is a narcotic mimetic, so keep that in mind. Opioids, like I said, no longer acceptable, okay? I only use opioids for if there was a generalized, if there was a flare, maybe they can't have an injection or something like that, I might give them 1 or 2 days, 3 days max. Injections, I do a lot of injections. So steroids are the most common, very cheap, will calm down the flare. Extremely easy to do. I would recommend that you guys try to get trained in that. If you know your anatomy and just find the joint lines, a very easy injection to do. And then physical supplementation is also really good. I tell my patients like WD-40 for the knee. So it is a lubricant for the knee. It's a protein that's harvested from the coxcombs of roosters, and it mimics the elasticity and buoyancy of normal synovial fluid. Your synovial lining, your knee, produces a very thick, buoyant, slippery joint fluid. As we get worse arthritis and our synovial lining, kind of goes to hell in a handbasket, you can't produce that. So if you draw fluid from that knee, it's going to be thin like water. You don't have that, so you get more grinding. So you put the visco supplementation so that it can glide more, less grinding, less inflammation, less pain.
A rooster?
From coxcombs to roosters. I don't know who figured this out, but it's a protein. Don't discount alternative medicine, okay? Teaching people to deal with their pain through meditation, acupuncture, it can be very beneficial. Lifestyle modification, diet and exercise, if they can lose some weight, the 1-to-4 ratio again, that'd be huge. And I tell them, 5 pounds people is 20 pounds of pressure on the knee. That 20 pound really gets their attention. That's a lot of that. All of a sudden, this, you know, in their head, that's a lot of weight. Braces, you can use them. Sometimes people are very funny about braces. Some people love them. Some people think they're spontaceidin. So I tend to have them get over-the-counter ones that don't cost a lot first before we try to do ordered ones. Ultrasound, TENS, physical therapy, we can put all that together. Weight would probably be the biggest thing. Physical exam, I always examine the uninjured knee just to see how it's doing. If it's specific injury suspected, do that exam last. This is the generalized physical exam. All right, so that ends it for arthritis. Okay, so I know the first 5 cases had pediatric as the case, but those are knee issues that span from the pediatric population into the adult population. So it is useful. I could substitute that age for anything. And we could have someone walking down the street instead of playing on the soccer field. This is very, very common stuff. You got to think about the mechanism of injury. A plant twist. Were they kicking a soccer ball, or were they chasing something? Or they all of a sudden were dropping their water bottle and twisted really hard. These are things that happen in the pediatric population and the adult population. Case 6 is a purely adult issue. We rarely have children that have any type of joint damage. If we do, it's because they had significant trauma. Okay? And then the other slides are just talking in general about how to do a physical exam. When someone comes in with a very, very painful knee, you don't want to just dive in and poke right away where they hurt the worst, okay? If they say, oh my God, my right knee and the medial joint line is killing me, I can barely walk on it, take a look at the left knee, get an idea of what their normal is, and then go and examine the right knee. And I always leave the area of where they say the most pain is for last, just because you're not going to be able to do a lot of this exam if they're tense and they won't cooperate, okay? And don't be afraid. I have patients who come in and they are in so much pain that me looking at them and they're screaming, I can't do an exam at all. If you have a patient like that, you have to decide, is it something catastrophic that we need to send them to the hospital? Or is it just that it's been so acute, we just got to give them time to calm down? So I might give them ice. That is where I might use a little bit of narcotics or prednisone to try to calm them down for a little bit. And then have them come back in a week and see if, do the exam then, because you need a good exam. I always inspect the knee first. Is there any effusion, edema, ecchymosis, muscle atrophy? Palpation. I always start at the tibial tuberosity. I don't know if I could.
You're going to have to pull his leg way over into the camera.
Let's see if we can get him over here. Here. Just put your leg up on the table, mister. Can you see that?
I think they could. I think they can.
So
if you can see it in the U.
Mm-hmm. I'm not on this screen.
Oh, okay.
That's okay.
Okay.
Am I over there?
No, it's behind. It would be behind there. You could just minimize your slides real quick to see if they can see it, and if not, then if you just minimize and see.
Oh, there I am.
There you are, and
Right.
there he is. So they will be
There
able
he
to
is.
see that. So you can put your slide back up.
So I always like to start at the tibial tuberosity, and I work my way up the patellar tendon. And a good way to find your medial and lateral joint line is to hook under the patella. If you hook your finger underneath the patella and then slide medially and slide laterally, you'll be directly on the joint line here, okay? I think his knee is a little bit too flexed. I don't think this is going to work out, sir. I then go around, I slide up and go around the medial and lateral edges of the patella. And then I look for any warmth, tenderness, assess for vascular integrity. You always want to check to make sure there is neurovascular intact. I do the joint lines, and then you're going to go into specific stressing of the ACL, MCL, LCL, and PCL. And then range of motion. Remember, normal range of motion for the knee is 0 to 135 or 145. You want to, while you're doing that, evaluate for the tracking of the kneecap and then palpate. You want to, if significant effusion does not allow for palpation to be performed at full extension, always put a pillow underneath their knee. Give them some comfort, okay? Some people cannot tolerate when their knee is injured to lie at a full 0 degree extension. So you want to pull them up. And then it's, when we go through, this is just a more general, this is more all on one side. Don't forget, when you're doing a lot of the testing, you want to test for the ligaments. Think about the way the ligament is attached and what motion is when you're doing the exam. Like I said, I could come back and do I could do an exam on a patient. I could actually video myself doing an exam. Would that be helpful?
Yeah,
Yeah.
I'm sure they would love it.
Okay,
Yeah.
very good. So, that ends the knee. It can be, like I said, applied very well. The whole thing except for case 6 can be applied to the pediatric and the adult population. And the case 6 is mostly for the adult population. Okay? All right, that ends that.